Welcome and thank you for joining us for today's webinar on ethical and pragmatic considerations in early liver transplant for alcohol-related liver disease, patient selection, equity and access, and strategies for success. This webinar is hosted by the Psychosocial and Ethics Community of Practice and supported by the Liver and Intestinal Community of Practice and the Society of Transplant Social Workers. Before we begin the main presentation, we have a few housekeeping notes to help you engage in today's session. Currently on your screen, there is a viewership poll. I kindly ask for you to please complete this poll to let us know how many of you are attending today's session. In addition, this webinar will be recorded and the archive will be available on the AST YouTube channel in about 2 to 3 business days after the live session. Please note that all your lines have been muted so that only the presenters can be heard clearly for the archive recording. If you have any question for our panelists throughout the webinar, we encourage you to participate by submitting your questions through the Q&A button at the bottom of your Zoom webinar panel. Questions submitted via the chat may be missed during the presentation. And finally, when you log off at today's session, you'll see a link to a short evaluation survey to complete. We kindly ask that you please complete the survey to help us keep our content current and engaging. And now I will turn the session over to the chair of the Psychosocial and Ethics Community of Practice, Dr. Jody Jones, for introductions.
Hi, thank you for joining us today for this next in the series of our ethics webinars. I am Jody Jones. As the chair of the Psychosocial and Ethics Community Practice, we really appreciate your participation today. I'm going to turn it over to our moderator, Dr. Grace Lee-Riddle.
All right. Hi, everybody. Thank you so much for joining. And I hope we have a great session. We have a great panel of speakers lined up. I'm going to start with, I have no conflicts of interest to disclose. So my name's Grace Lee-Riddle, and I'm an abdominal organ transplant surgeon at Thomas Jefferson University with a particular clinical and research interest in liver transplant for alcohol-related liver disease. I also completed a fellowship in advanced biomedical ethics during the research years of my surgical training. I'm a former member of the AST PSECOP Executive Committee and continue to help coordinate and manage the ethics and transplantation webinar series like this. I'll be giving a brief history of liver transplant for alcohol-associated liver disease in the U.S., and I'll be moderating the discussion following the speaker presentations. Our speakers are a multidisciplinary group of folks from all across the country and Canada. So first, we'll be hearing from Dr. Brian Lee. He's a transplant hepatologist at the University of Southern California. He served his gastroenterology and hepatology training at UCSF before he arrived at USC, where he's now an associate professor. His clinical and research interests focus on improving health for patients with alcohol use and liver disease, with an emphasis on early transplant for alcohol-associated liver disease and public policy. He's an NIH-funded investigator who studies early liver transplant for alcohol-related liver disease, and is also the founder of the Accelerate Consortium, which is the largest group studying early liver transplant for alcohol-associated liver disease. Next, we'll be hearing from Joshua Sumner, who is a social worker at Indiana University Health and Riley Hospital for Children, where he works with adult and pediatric liver, intestine, and multi-organ transplant recipients. He's also a decorated U.S. Army veteran who initially worked at the Indianapolis VA after his honorable discharge before transitioning to the transplant program. His research interests focus on improving patient help-seeking behaviors, social work ethics in organ transplant, and enhancing provider resilience. He will discuss psychosocial considerations in the evaluation for early liver transplant and mechanisms to support early liver transplant patients and their families prior to transplant. Dr. Josee Lynch is an addiction psychiatrist at Toronto General Hospital's Ajmera Transplant Center. Her clinical and research interests include improving outcomes for patients with alcohol-associated liver disease requiring liver transplant, development of novel postgraduate addiction curricula, and improving access to treatments for patients with substance use disorders. She's a psychiatry lead for the Ontario Alcohol-Associated Liver Disease Project, a novel multidisciplinary program with the goal of providing access to transplant for patients with ALD and short periods of abstinence through in-depth psychosocial assessment and integrated addictionist treatment. And then last but not least, we'll be hearing from Dr. Alexander Zambrano. He's a philosopher and bioethicist at Loyola Marymount University, where he teaches both in the philosophy department and the bioethics institute. He received his PhD in philosophy at the University of Colorado at Boulder, where he focused on biomedical ethics. His dissertation was on the ethics of organ transplantation, particularly as it relates to various issues regarding patient autonomy. He's written on the various moral problems that arise when thinking about organ allocation and moral responsibility, as well as issues related to informed consent, presumed consent, and the family's role in organ procurement. Dr. Zambrano will walk through the ethical considerations regarding personal responsibility as a factor in organ allocation. So without further ado, I'll be covering some definitions and trends that are related to liver transplant, particularly in the US. So I found all these terms that are related to alcohol and transplant somewhat confusing, and to try to make it a little bit simpler for myself, I think it's helpful to have a flow chart like this, where you see that alcohol-associated liver disease, or ALD, is the encompassing umbrella term that covers simple steatosis from liver injury from alcohol use to fibrosis and the development of cirrhosis, and also includes alcohol-associated hepatitis, or the acute inflammatory syndrome that occurs with acute increases in alcohol use that affect the liver in a severe and acute way. So when you look at alcohol-associated hepatitis, a subset of alcohol-associated liver disease, one way to define it is hyperbilirubinemia with a bilirubin greater than 3 within the past 8 weeks, noting an acute change. AST levels greater than 50 with AST-ALT ratios greater than 1.5 in patients with a history of heavy alcohol use and the absence of other reasons to have liver injury. A lot of patients who present with an episode of alcohol-associated hepatitis already have underlying cirrhosis, but the initial time that they present with alcohol-associated hepatitis may be the first time that they also discover that they have underlying cirrhosis. And it can be very severe. It's associated with a 90-day mortality risk of 30 to 50%. And yeah, so I will go with that. Alcohol use disorder is another term that comes up when we discuss early liver transplant for alcohol-associated liver disease. And alcohol use disorder is a medical condition with impaired ability to stop or control alcohol use despite having adverse consequences, whether that's your personal relationships, your work, your health. And it's a formal diagnosis in the Diagnostic and Statistical Manual with very specific criteria that then categorizes you as mild, moderate, or severe alcohol use disorder. The prevalence of alcohol-associated liver disease, in a 2023 systematic review and meta-analysis, it noted that the global prevalence can be 3.5% in the general population, 26% in those with hazardous use of alcohol, and then 55.1% in alcohol use disorder populations. And so you can see that the prevalence of alcohol-associated liver disease, covering the spectrum of alcohol-associated hepatitis to steatosis to cirrhosis, is dramatically different based on your alcohol use. And this is likely an underestimation because, as I said before, sometimes people have compensated cirrhosis, or they don't realize they have liver disease from their alcohol use. And so when they present clinically, that's when we can actually measure the fact that they have liver disease associated with their alcohol use. And so the true prevalence is probably much higher than this. I'm going to give some historical context on the concept of a 6-month sobriety rule for patients who have a history of alcohol use that require liver transplant. In 1997, this was a consensus paper that was developed between the American Society of Transplant Physicians and the American Association of the Study of Liver Diseases. And what they note in their paper is that one of the concerns with listing patients for alcohol, what they call alcoholic liver disease, is that there's a possibility of returning to alcohol abuse. And they note that by having a 6-month abstinence requirement, they understand that they, in effect, exclude all patients with alcoholic hepatitis for liver transplant. And then they also recognize, even then, that the data regarding the utility of this abstinence period is somewhat conflicting. But that's why they created this pathway for regional review boards to find exceptional patients who don't meet the 6-month requirement, who could then potentially go on to get transplanted with a liver. So that was a long-standing rule of thumb that a lot of transplant centers used to help guide them in understanding how they decide who to list for transplant with alcohol-associated liver disease. And then a landmark paper came along in 2011, where in France, a multi-center study looked at a highly selected group of individuals who could potentially receive an early liver transplant before the 6-month sobriety period. These are people who did not respond to medical therapy. This was their first liver decompensating event. They had the presence of close supportive family members, had the absence of severe coexisting or psychiatric disorders, and would agree by patients, the patients would agree to adhere to lifelong total alcohol abstinence. They found 26 patients that they were able to transplant. The median MELD for these patients were 30. So what they're capturing are people who are very acutely ill, these patients with acute alcohol-associated hepatitis, that otherwise would not have made it to transplant if we had to follow the 6-month sobriety rule. The 6-month survival for the early liver transplant group was 77%, whereas a case control study of a similar matched cohort showed that the 6-month survival would be 23% without early liver transplant for this particularly sick population. Ultimately, 3 of 26 resumed alcohol use, so that was 12%, and they occurred at 2+ years at 720, 740, and then 1,140 days post-transplant, which was much lower than people expected. I want to then transition from the concept of understanding the 6-month sobriety rule to then recent times with alcohol-associated liver disease and the COVID pandemic. What we saw was as the COVID pandemic hit, there was a rapid increase and a sustained increase in the number of alcohol-related deaths for patients. And then when we looked at the number of patients who were acutely ill, requiring with high MELD scores demonstrating severity of their illness with associated alcohol-associated hepatitis, who then got listed and transplanted, that also dramatically started to rise after COVID. And now we've gotten to the point where the most common primary diagnosis amongst the adults who are waitlist candidates in the US are alcohol-associated cirrhosis or alcohol-associated hepatitis. And that you could see these trends from 2012 up to the most recent OPT and SRTR report showing that nearly 40% of the patients that we are transplanting have the diagnosis of alcohol-associated liver disease. And that's been a very dramatic change from the last decade. And so because of that, as the field evolves, we wanted to ask in this webinar, can we improve patient selections for alcohol-associated liver disease, particularly alcohol-associated hepatitis and liver transplant? How can we ensure equitable access in a changing field? How have transplant centers adapted to this increased demand for comprehensive psychosocial support and proactive intervention in alcohol-associated liver disease? And should allocation policy take personal responsibility into account as we see that this has become more and more common as an indication for liver transplant? So with that, let's have a great webinar.
Hey, well, that was a fantastic introduction. So, I'd like to thank Grace and the organizers for inviting me here to talk about this important topic. And what I'll focus on is selection and strategies for success. So here are my disclosures. How I frame this topic is that we'll first talk about some epidemiology and background about early liver transplantation for ALD and LCAP. We'll talk about process and specific evidence-based tools that can help you with clinical and psychosocial selection. And we'll end by bringing this all back together with an example of how we practice at USC. So severe LCAP represents a subset of ALD. Mortality is up to 70% at 6 months, and there are no pharmacologic therapies that benefit long-term survival. Patients with severe LCAP were historically not eligible for liver transplant, and this is largely due to the 6-month rule, which was actually an arbitrary suggestion at an NIH consensus meeting for liver transplant in 1983, where a patient with ALD was required to have 6 months of abstinence for alcohol to be eligible for transplant. So why did people think that the 6-month rule would work? One of the initial thoughts was that the 6-month rule would allow time for the liver to recover with abstinence from alcohol. A patient with severe LCAP might recover and not need an unnecessary transplant. But we now know much more about the short-term disease course. We can predict with high accuracy who will recover and who will not, with more sophisticated prognostic models like the joint effect model here, which combines MELD and allele scores. More recently, we published a multi-center study amongst our Accelerate consortium. So here we included a random sample of 145 patients who were evaluated for early transplant with LCAP, with a MELD score greater than 20 and alcohol use within 6 months of evaluation. You can see on the bottom left figure, you have the probability of being alive and recompensated as the dark bar. The light bar is alive and decompensated. The 6-month probability of being alive and recompensated was only 7%. Probability of being alive and decompensated was 34%. So the remaining patients, over 50%, are dead at 6 months. On the right, you have patients who were declined for early transplant because they were thought to be clinically improving during the evaluation. 6-month probability of being alive and recompensated, even in this group, was only 19%. So the main message here is that most patients declined for early transplant are dead at 6 months, and the majority of survivors retain an indication for transplant at 6 months. Another thought was that abstinence before transplant could be a surrogate for a patient's ability to abstain from alcohol use after transplant. Since then, there have been a number of studies which show that the 6-month rule is an unreliable predictor of post-transplant relapse. More importantly, we now know that there are many predictors of alcohol relapse, so why should one, i.e. length of abstinence, have veto priority above all others? So our consortium has really tried to inform the community about the selection process. In other words, who is the appropriate candidate for early transplant? So this is a complicated question, but at its base, I divide it into two broad categories. The first category is clinical criteria. We're looking for a patient who's at high risk of short-term mortality without transplant, who's too sick and unlikely to survive participation in formal alcohol rehab before transplant, and would derive significant survival benefit from an early transplant. If they meet clinical criteria, I then move on to assessing psychosocial criteria. Here, we're looking for a patient that, despite a short duration of sobriety, would be at low risk for alcohol relapse after transplant, and/or their alcohol use disorder is anticipated to be manageable post-transplant. And something that's very important here is that with the stigma associated with alcohol use disorder, we need objective and standardized criteria. Subjective criteria are vulnerable to bias and cause inequity in access to early transplant. So to inform the first category, clinical criteria, we teamed with decision analysis experts from Mass General led by Chad Cotwell. We developed a mathematical model which simulated 10,000 patients with severe LCAP, offered early versus delayed, i.e. a 6-month weight transplant, with varying levels of alcohol use, pre and post-transplant. We found that offering early versus delayed transplant increased average survival time of patients, a 4.49-fold increase in our base case analysis. The survival benefit of early transplant was maintained in all simulated extreme scenarios, including any estimated risk of sustained alcohol use after early transplant. So we found that the survival benefit was highest for patients with a MELD score of 32 or above, and a allele score between 0.50 and 0.82. These are the patients who should be prioritized for an early transplant. We also found that 64% of the survival benefit of early transplant is lost in the first 3 months. This emphasizes the importance of an early referral and an efficient early transplant evaluation. So for psychosocial criteria, I can't emphasize how important it is that this evaluation be standardized. The initial evaluation should be done by professionals with specialized expertise in substance use disorders, typically a social worker or addiction specialist. The evaluation should use objective and consistent criteria. The evaluation should be supplemented by adjunct tools, which are validated and can accurately predict post-transplant relapse. This evaluation will often then be discussed by the entire transplant team, and members need to be sensitive to existing stigma, disparities, and potential biases. And finally, when a decision by the transplant team is made, consensus decision should really be the goal here. We shouldn't be allowing single voices in selection committee drive selection decisions. So the psychosocial evaluation has to be comprehensive because there are many factors that affect post-transplant relapse risk. It's important not to anchor on a single risk factor like length of sobriety or other ones. A comprehensive psychosocial evaluation can take hours. It can be really hard to parse through all that information in a short selection meeting. So I always say that it's important that the experienced social worker and or addiction specialist provide a summary risk assessment at the end. So we published a secondary analysis for Accelerate cohort, which produced a scoring tool that could be used as an adjunct before transplant to identify patients at low risk for sustained alcohol use after transplant. We've called this the SALT score. Our analysis found 4 objective pre-transplant variables commonly collected during the transplant evaluation to be strongly associated with sustained alcohol use after transplant. These 4 variables: more than 10 drinks per day at presentation, 2 or more prior failed rehab attempts, any history of prior alcohol-related legal issues, history of non-THC illicit substance misuse, were assigned points to form the SALT score, which ranges 0 to 11. At a cutoff of 5, the SALT score has an accuracy of 76% to predict sustained alcohol use after transplant. It has a negative predictive value of 95%. This most appropriate use is for predicting those at low risk for sustained alcohol use. The maximum positive predictive value at a score of 11 is only 50%. So a recent national survey shows that the SALT score has been incorporated into protocols for more than a third of transplant centers across the country officially. And the SALT score has been validated by external groups in the broader transplant for ALD population, not only LCAP, to have similar accuracy. So putting this all back together, how do we bring this information back to our clinical practice? And I'll show you the example at USC. So here at USC, we have no mandated period of abstinence for transplant candidacy. In 2021, the last time we did a deep dive for this data, we did 70 transplants for alcohol, which represented 41% of our total liver transplants for that year. 34% of these patients were with less than 6 months of abstinence, and these patients had a 54% listing rate for early transplant candidates that were presented at the selection meeting. We've revised the selection protocol to reflect recent advances in evidence. I've done this twice now in the past 5 years. All transplant candidates are evaluated by social work. Potential transfers are evaluated remotely with the standardized checklist, which we've published. SALT and CyPAT scores are included as adjunct tools to the social work evaluation. So all patients have SALT and CyPAT scores. Addiction psychiatrists formally evaluate all patients deemed high risk by the social worker, and by default, all patients with less than 6 months of abstinence are considered high risk by our protocol. And there's an addiction psychiatrist and social worker at each selection meeting. We've also standardized how we monitor for alcohol relapse post-transplant. We have clinical interview and PEP testing at least every month in the first year post-transplant, which is the highest risk period, and at least every 3 months thereafter. So in conclusion, transplant for ALD and LCAP are on the rise. Accurate, objective, and consistent risk assessment of post-transplant relapse is critical to transplant selection and post-transplant management. Finally, alcohol use after transplant, despite best efforts, still has high prevalence, whether we like it or not, and is associated with poor outcomes. So interventions and further research is needed to prevent and treat alcohol relapse. Thank you.
Give me just a sec here. Hi, I want to thank everybody for having me here today. So I'm going to talk to you about what social work does and things that we look for, pretty similar to what Dr. Lee had said earlier. Yeah, no conflicts of interest there. You've just been disclosed. Quick ethics review, just to help me keep my thinking straight. When I'm talking about clinical ethics, I think of justice, benevolence, non-maleficence, and autonomy. And I always like to add the couple of virtues of prudence and veracity. The idea of being truthful, and the idea of using research and doing in-depth evaluations, all for the betterment of equity and reducing bias in this population. So alcohol misuse and liver transplant, is it ethically appropriate? There's 4 things I want to look at. Alcohol use disorder as a disease model. I want to look at American culture and drinking behaviors. We've already talked about COVID. I'll touch on it briefly. And some psychosocial considerations, and then what our center does. So addiction as a disease, this is pretty widely accepted. For the deep research, you have KOGA and the NIAAA that pumps out a lot of stuff on alcohol use disorder and how that relates as a genetic and biologic disease. So here's some reframing. The word alcoholic is considered offensive. It's a person with alcohol use disorder. We no longer address it as alcoholism. It's an alcohol use disorder. But this idea of it being a moral failing, evidence and research suggests that it's a biological and it's a disease, and we need to treat it as such. And so, there's treatment versus punishment. And the big thing I like to emphasize here is everybody deserves a pathway to health and wellness. There should be a way to do that. When I give this presentation, I think about, and I don't use the example too often because not everybody knows about it, but the example of George Best. So, late 90s, early 2000s, it was pretty widely accepted that alcohol use disorder was a biological disease. And George Best, which was a famous footballer in New England, got transplanted in 2002. And he's a pretty public figure, and then publicly relapsed and got liver failure after his transplant and ultimately died from it in 2005. And in Europe, this was a big deal, and the public got upset. And at that time, they were looking at readjusting the 6 months, but that just sort of strengthened this idea that we should maintain it. And then we heard, of course, from Mathurin in what he's done to sort of change the landscape. American drinking culture. What does environment teach us about alcohol use? I always think I use my children as examples. For those of you who have children and a commercial for alcohol use comes on TV, I think, what is this communicating to my child? And, alcohol looks fun. It really does. In my longer presentation, I show a couple of commercial videos about, with Jack Daniels and Corona and several other wine and spirits manufacturers and what they're pumping out to the public to get them to drink. And I find it interesting. I go and find, next slide. So here's some decorations that you can buy for your home that I've seen and that my children have seen, which is the example. And I really think about what does this talk about our culture and drinking as it relates to liver transplant, and what is this teaching my children? And so a lot of this, of course, is tongue-in-cheek, but I think it communicates a levity that is unwarranted. So currently, we are seeing alcohol use decline in the population overall, slowly overall, but young women and wine culture, there's a peak there and a crisis that some have identified that we worry about with under 30 and heavy wine use in females. Here's my brief bit about Corona. COVID changed the game a little bit. This is a screen grab from the movie 28 Days Later. It's a zombie flick. Fellow wakes up after a coma, and the whole world has changed. And he's walking through downtown London, and there's nothing. So that's what it was like when the lockdowns hit. So in Indiana, lockdown hit hard March 16th. And so with drinking culture and American behavior, what that did is even, it cut out your commute. So even if you weren't drinking during work time, you didn't have an hour commute home, so you'd start your drinking an hour earlier. Drinking increased among everybody. After the lockdowns were restricted, other substance use went back down to baseline. Alcohol use stayed the same and remains the same. It's very high. Here's another example. I don't know if you guys remember Drizzly as an app. This was developed in 2012 12, I think, in Boston. A couple of college kids put it together, and they finally released it in 2013. In 2020, the use had multiplied tenfold. The average basket, meaning what people are putting in to purchase, went up 1,000, a little bit north of 1,000%. So people are stockpiling alcohol more frequently and getting it delivered to their house. Eventually, Drizzly was bought out by Uber, and then it was absorbed by Uber and changed to Uber Eats. At that time, the company was so well-to-do that Uber paid them $1.1 billion to take that over. So, yes, lockdowns, COVID, but you could still have it delivered to your house in under an hour. So, psychosocial considerations for looking at folks with who could benefit from early transplant, meaning less than 6 months of sobriety. In 2019, just before COVID hit, they had the Dallas Consensus Selection Criteria. I'm sure most of you are familiar with that. And they put together this group of limits that was recommended that centers use. And for the most part, centers do keep to that. Here is an article that came out in 2021 by Dr. Lynn and the rest under liver transplantation. So they surveyed, it was 117 liver centers, liver transplant centers, 100 responded. And this is what they got. And what is interesting is 100% of those who responded that they work with patients who need early liver transplant. Adequate caregiver support was deemed to be the most valuable criteria in maintaining sobriety long-term and benefiting somebody to handle a transplant long-term. Adequate caregiver support, as Dr. Lee had mentioned, there's a lot of variables there, and that criteria isn't very specific. So what we look for here at IU University Health is we want to make sure that their social support, they have at least 4 people who can help them out. The people that they live with are also dedicated to sobriety. And we look for how they use their time. Is their social support structured time? We find that reduces the temptation to drink for caregivers. Along with this also goes along with the normal criteria that is used for people with longer than 6 months of sobriety. The way I sort of frame it to folks is, think first-time offenders. This is a group of people that, if they genuinely didn't know how dangerous their alcohol use was, had never been told by a physician or been told that they should stop drinking due to their health, and this is the first time they've been admitted to a hospital for a drinking-related incident, and their hepatitis is severe enough that they're not going to make it without a transplant. Should transplant be precluded from this group of people? And it shouldn't. Which was Mathurin's issue, that he said that with highly selected people, they can do just as well and sometimes even better long term with their sobriety than people with more than 6 months under their belt. So I talk a lot about non-compliance and non-adherence. Non-compliance is sort of this willful disobedience. Non-adherence is usually what, when psychosocial barriers are more important than their medical, what we call trade-offs. This isn't a willful disobedience or not wanting to be healthy. This is like survivability. For example, if your income is such that the choice you have is to buy your immunosuppressants or buy your children food, you'll buy your children food first. And so that's not non-compliance. That's a non-adherence. One of the things that's really very interesting is measuring deception and how that works. Somebody shows up to our facility and they have less than 6 months sobriety. They need a liver transplant. I walk in and I say, I'm a liver transplant social worker. I want to ask you about your social history. They know why I'm talking to them. So that incentive to lie is overwhelming, and people underreport. And so we know that. I would underreport if I were in their shoes. I think most people would. And even if you're not in the context of needing a liver transplant, people typically underreport their drinking anyway. When you actually measure it, it's usually way more than people realize. And so deciding if how strongly we should weigh deception as an ethical criteria is really difficult. We know it's something that happens, but it's just something that social work thinks about and monitors. This is a screen grab from our acute alcohol-related hepatitis policy and how we choose to vet these people. And so I use these criteria. In fact, when I'm talking to folks that need alcohol need early liver transplant, I have a printout that I bring to make sure I'm sticking with this criteria and going through it. And then separately at a different visit, our psychology team does the same thing. And, we see how accurate our results are and discuss that. And of course, at committee, we're looking for a consensus that this is a person that we think would be able to manage a liver transplant long-term without an early relapse. So one of the physicians I work with, Dr. Ashna Singh, put this together. I'm using our criteria. This is our fishbone chart. This is it's much prettier to look at than what I put together. So looking at this criteria, and was also touched on by Dr. Lee, deciding how to measure these things can be really difficult. For example, what does it mean to have insight? How do we measure that? How do we assess whether a patient has an appropriate amount of insight to move forward or doesn't have insight enough to move forward? Co-occurring psychiatric illness. People can struggle with their mental health and be successful in liver transplant. Specifically, what we're looking for is things that impact that compliance or adherence. And more often than not, it's not a mood disorder, it's a thinking disorder. When we see a thinking disorder paired with a history of polysubstance use, that ups that risk level, stratifies that risk differently. I talked about support and stability. First episode, if you ask a person, has a physician ever told you to stop drinking before? Sometimes they don't remember. Sometimes they're afraid to share that. What does that consequence mean? And sometimes we'll have to look that up with the chart review. So, trying to remember formal logic class from years and years ago. And here's some premises I put together for a syllogism and to kind of make it easier to swallow that alcohol use disorder, it is ethically appropriate. So if we think these things are true, these statements are true, if this is something that we agree with, meaning alcohol use disorder is a biologic disease should be treated medically, medical criterion should govern eligibility heavier than other criterion. It saves lives. We know that unequivocally that it saves lives. And there's no link to 6 months of sobriety, long-term sobriety. Then patients with acute alcohol-related hepatitis are eligible for transplant. It is ethically appropriate, and we are obligated to offer it. So that's all I have. I am running an active research program to dig more into psychosocial evaluation. If you're a person who evaluates patients, hit up this QR code, and I'd like to know your ideas. I appreciate your time. I think I went a little bit over. Sorry. Thanks for having me.
Hi, everyone. Are my slides up and okay?
Yes.
Excellent. So hi, everyone. It is my absolute pleasure to be here and to partake in this important conversation today. What I will be doing is taking us over on the post-transplant side, where we'll be discussing pragmatic strategies for integrated psychosocial post-transplant care. So moving right along, because we don't have a ton of time, I do not have any disclosures to report. What I'm hoping to accomplish in the next 8 minutes or so is to give you a bird's eye view of what integrated post-transplant addiction care can look like. But I want to give you enough details so that it's practical and you're able to implement some of these tools in your own practices. And throughout this, I'll be weaving in how a nuanced understanding of alcohol use disorder can really help us design a program that is most likely to be beneficial to ALD patients. We'll be talking about pragmatic strategies for implementing this, and we'll also get more granular and list the roles and contributions of various psychosocial team members. So the first thing that I would like to start with, this might be obvious to many people, but I think it's still very important to say it out loud, is that liver transplantation does not cure alcohol use disorder. So it's already mentioned that alcohol use disorder is a chronic, relapsing, and I will add treatable biopsychosocial disorder of the brain. And a great majority of patients referred for liver transplant for ALD meet criteria for this condition. So in our program in Toronto, 85% of referred patients have an AUD, the majority of which meeting criteria for a severe form of the condition. And on the post-transplant side, 76% of those approved and who received transplant meet criteria. So it's very important to pay attention to this, because I would argue that if we are offering transplants to patients and we're expecting them to avoid alcohol forever afterwards, but we're not planning ahead as to how to treat their alcohol use disorder, what we're essentially doing is believing that the transplant cures the alcohol use disorder. The second thing I think that's very important to understand is that alcohol use disorder fuels avoidance. And I'm talking about capital A avoidance, and I'll speak more about how that manifests and can get in the way. But first, a few numbers to give you a sense of what I mean here. So AUD is a highly prevalent condition. 11% of people in the US will meet criteria for it at some point in their lifetime. Less than 15% of these individuals will eventually receive treatment for it. And of those who do, there is an average 8-year lag between the development of the condition and engagement in treatment. And I'm sure that many of you have encountered many patients who present to your liver transplant center whose lives have been decimated by alcohol and alcohol use disorder. But this, when they're in liver failure, is the first time that they present for care. So what is going on here? What is the problem? So I think it all boils down to stigma, and stigma creating barriers for patients to access healthcare. And this has been written about quite thoughtfully in this article that I'm summarizing briefly here, but that says that the stigma can be categorized in 3 separate buckets. So there's social stigma, and Joshua presented many slides that illustrates how, as a society, we do a very poor job of talking about alcohol. We glorify it, we romanticize it, we advertise it. But the second that somebody crosses the line into an alcohol use disorder, all of a sudden it's taboo. We don't talk about it. We don't talk about Uncle Bob. It's something that is seen as shameful. And that message is internalized by our patients, and they carry it as self-stigma, and that often manifests as denial. It takes a long time before people are willing to admit that they need help with their alcohol use, because they believe that if that is true, then they have a moral failing, that they are bad. So again, introducing a barrier to them seeking treatment that they need. And finally, the third bucket talks about structural stigma. And that relates to how historically addiction treatment has evolved outside of the conventional medical setting. You go to an outside addiction treatment center to be treated for alcohol or opioid use disorder. It's other. And again, it's a big ask to have patients who already are feeling pretty bad about this condition to go and to identify with this type of treatment program. So it's these different types of stigma that we had in mind in our program when we chose to develop our program. And the goal here is to chip away at these barriers. And this is how we have done it. So this is a general breakdown of how our program is run in Toronto. Everyone who receives a transplant automatically is followed by transplant hepatology, of course, but we have integrated addiction psychiatry. So they are booked automatically with the addiction psychiatrist that saw them for their pre-transplant assessment, whether or not things are going well. And then we tend to follow them for a year at varying frequencies, depending on what the needs are. And for patients who are deemed to be higher risk or more complex, we follow forever. If someone is doing well at the end of that year, usually we conclude regular follow-up, but we always leave the door open for re-engagement. And what we've accomplished in that year is really building a relationship where if the person struggles in the future, they're a lot more likely to reach out to us for support. We also have an addiction therapist, although they don't become involved unless somebody returns to drinking or expresses difficulty with cravings. And we have a transplant social worker. Most of their work is around the peri-transplant period, but they're available post-transplant as well, if need be. And one very important detail here is that this is all done on a backbone of routine biomarker testing. So we do urinary ETGs when they're providing their blood work, a urine test outside of the hospital. When they're on site for their clinic follow-up, we do PET. So together with that information and the relationship we build, our goal is to really help patients continue to avoid alcohol post-transplant. So here are more kind of granular post-transplant tasks of what we do. So of course, we treat the alcohol use disorder with medications and behavioral interventions or therapy. We provide psychoeducation about alcohol use disorder to the patient as well as their family members to again chip away at that social stigma. We screen for psychiatric comorbidities and treat them when they exist. There's also a lot of general psychosocial support. You know, living with a transplant is no picnic, and a lot of things come up where people benefit from having a space to discuss these challenges. We also keep an eye on the biomarker monitoring along with the hepatology team. And really the secret sauce, as I like to say, is really that therapeutic alliance, is to have a consistent point person that the person is familiar with and feels comfortable sharing openly. So I wanted to share this slide to explain why we decided to leave the door open indefinitely and why I think it's important to have a long game in mind in terms of having people supported for the rest of their lives, essentially, is that although most of the harm that comes from post-transplant return to drinking is in those who have early return to drinking post-transplant. This was a study that followed 200 and some patients and that modeled the different patterns of alcohol use after transplant that can occur. So group 1 and 2 is the dream. So those are patients that either did not drink or had minimal fluctuating use. Group 3 and 5, the yellow and the green, are those that had fairly early alcohol use that then tapered off. Those are the ones with the most morbidity associated with their drinking. But pay attention to group 4, who had minimal use until 3 years and then a steady increase afterwards. And what I see anecdotally is that when people get thrown curveballs after a few years out, it's hard not to fall back into old habits. And often alcohol can sense an opportunity and sneak in there. So when someone reaches out to me after 3-5 years saying they're struggling and I get to work with them again, I see that as a huge success. So I won't go through these in details, just keeping an eye on the time, but these are some benefits of an integrated team that you can read through, and really it's addressing those barriers. And finally, this is an article that I like to put a plug in. It's very practical, different models of having addiction treatment connected with liver transplant programs in various degrees of integration. So thank you very much. I will stop here.
Okay, so can everyone hear me okay? All right. I'm just going to start this from the beginning. Okay, awesome. Thanks to the other presenters for really great presentations. I learned a lot, honestly, from all your presentations, and thanks for having me. So I'm going to talk about a more sort of philosophical and ethical issue that arises in liver allocation for alcohol-related liver disease. I'm going to think a lot about some ethical arguments that are found in the ethics literature. So there's my conflict of interest disclosure. Where I want to begin is in this sort of general question, should allocation policy take responsibility into account? And I think that's a kind of ambiguous statement. There's lots of ways in which we could, try and answer this. We could ask in what sense should we take responsibility into account? It turns out that in the ethics literature, in the bioethics literature, there's a very famous paper that came out in the early 90s in JAMA by Alvin Moss and Mark Siegler, and their answer to this question was yes, we should take some responsibility into account under certain conditions. What they proposed, however, a lot of people disliked, some people agreed with them. What they proposed was a policy that I have dubbed in my work the lower priority policy, or LPP. The lower priority policy is essentially the idea that patients who are morally responsible for their alcohol-related liver disease, and I'll explain what moral responsibility means in that context, those patients should receive, in some sense, lower priority for liver transplant when they're competing with other patients who have no moral responsibility for their medical condition and also need a liver transplant. So it's in a sense when they're competing with others who are not alcohol related patients. Now, Moss and Siegler and others who support this policy in the ethics literature, they've tended to view this as a tiebreaker policy. In other words, when the medical facts between two patients are basically similar or identical, uh, this policy should be used as a tiebreaker. So if there's two patients competing for, let's say, a donor liver, one of them is an alcoholic patient, the other is not, the idea is that this would be used as a tiebreaker and it would go to the non-alcoholic patient. And they're clear in their work, and I think everyone would agree with this, that this is not a universal ban for alcohol-related liver patients. This is just a small way to fix the allocation policies. Now, of course, this is quite controversial, and there needs to be an argument for it. So there's a pretty straightforward argument that Moss and Siegler and others who defend this view give. I'm going to call it the responsibility argument. It's pretty straightforward. It says that alcohol-related liver disease patients are morally responsible for their medical need. And again, I'll clarify that term in a second. And then the second claim that they make is a very important one. Patients who are morally responsible for their medical conditions should be given lower priority for treatment when they're in competition with patients who are not morally responsible for their need. So in other words, this only applies in cases when there's competition for scarce resources between patients. And therefore, alcohol-related liver disease patients should be given lower priority for a liver transplant. Okay, so that's the kind of basic argument that supporters of the lower priority policy give. So the key question here is, what do they mean by moral responsibility for their medical need or for their, alcohol-related liver disease? Well, they mean different things. So Moss and Siegler, in their original analysis, they tend to view the term responsibility like this. They tend to say that to be responsible for your liver disease means that you failed to engage in what they call a good faith effort to curb alcoholism. What they mean is you failed to at least try and seek treatment at some point in your life, given that apart from acute cases, the condition takes, several years to develop. However, other defenders of this view disagree. Walter Glannon says, well, responsibility doesn't mean failing to engage in a good faith effort. It means having causal control over the events that led to alcoholism, meaning maybe you're not in control when you're in the grips of alcoholism, but you had causal control over, the first few drinks or the first series of drinks that led you into alcoholism. Of course, these are controversial ideas, as many of you probably know. So one thing that I want to mention about Moss and Siegler's conception of responsibility is that they do think that if you did try and curb alcoholism through a good faith effort at treatment, then you're off the hook, essentially, that we won't lower your priority for treatment. Okay, so in applying this to early liver transplantation, it's quite straightforward, and I'm going to go through this quickly. Other people already talked about this. So, as you know, in allocation, these alcohol-related liver disease patients will compete with non-alcohol-related liver patients for liver transplants for donor livers. And the idea here is when they're both medically similar, right? They have about the same medical need. Their prognosis is about, the same. Both maybe won't relapse or both won't consume alcohol after. The idea is that the non-RLD patient should receive the transplant. However, if deemed non-responsible, if maybe they, did actually put in a good faith effort, if they lacked causal control over their alcoholism, then the proposal is that the ARLD patient is not penalized. Okay, so that's the idea. Now, I actually don't think this is a very good policy. I actually there's a lot of different arguments against it that I think are compelling, and I want to share those with you. So the first two uh, problems center around issues related to determinations of moral responsibility. So we might ask what constitutes a good faith effort at curbing alcoholism? What does that even mean? Does it mean that I enrolled in treatment one time and I tried for a week? Does it mean, I tried till the end of the treatment time? It's a little bit ambiguous and vague. And then the second question is, given that we view alcoholism as a disease, to what extent do individual patients have causal control over the alcoholism? You might think that in general, the answer is they have very little. And yet, I think some of these authors still think we should hold them responsible. Another problem for the view is given by philosopher Dien Ho. Dien Ho, in an article that came out in 2008, argued that this policy undermines the physician-patient relationship. Here's why. Physicians need testimony from their patients about their lifestyles to make this ARLD diagnosis. They need to know what their habits are, what their history is. But if patients knew that alcoholism would preclude them or give them lower priority for treatment, patients would withhold information or would be at least motivated to withhold information in fear of getting lower priority. And so the end result of this, according to Ho, is that physicians won't be trusted and suboptimal care would result. Okay, the last argument or the last issue with the responsibility argument is a little bit more abstract. I call this the social value argument. It's a little bit conceptual, but here's the idea. We can think of a host of hypothetical cases in which a patient needs an organ transplant because of behavior that they engaged in. Particularly, we can imagine engaging in socially valuable behavior like a firefighter who needs a lung transplant. So I think most of us are not prepared to say, well, there should be a policy that, even if a firefighter needs a lung transplant, we should lower their priority. So what I argue is that this view has to be amended to exclude socially valuable behaviors. Problem is that this exclusion is inconsistent with what I call state neutrality on the good life. And what that really means is that the state's decisions should not involve preference for a particular conception of the good life. What I mean by the good life is what brings value to individual lives. And in pluralistic society, the idea is we should make allocations decisions based on some preferred conception of what people enjoy in life or what the good life is. And we can talk about this more in Q&A if you like. The final thing I want to share is, there's other issues here. Does a patient deserve a transplant given active alcohol consumption, especially in early liver transplantation? I think the answer is pretty straightforward. As persons, all patients deserve access to life-saving treatment. Furthermore, many of these candidates, as we've just seen, will die within, days or weeks without a transplant. Another question is it acceptable to give a new liver to someone who might ruin it? And I think the answer is yes. The same would be true for, ARLD patients who meet the 6-month sobriety requirement. Like it's also possible that they relapse. So I don't think that rules out active alcoholics from liver transplantation. Okay, that's all I have for you. I think that's my time. So thanks, everybody.
Wow. Well, I just want to thank all of our panelists. I think that this was a great session thus far, and thank you to the audience. We are getting a lot of questions, so we're not going to have time to cover them all here, but I think we as the panelists are going to do a separate Q&A session where we'll go through all of them, but let's hit a couple of the questions to start. So first question that I want to ask from the audience is, what are your recommendations in initiating the discussion regarding abandoning the 6-month sobriety requirement for your transplant program?
I think it can be helpful to show data, right? So there's a global survey now that showed that surveyed all US centers, 97% of transplant centers now offer early liver transplantation. So if you're one of the 3%, you're really not following standard of care. All national guidelines now, including the AST, the ASLD, say that early liver transplantation in carefully selected patients is standard of care. And that's where I would start that conversation.
I don't know if Joshua or Jose, where you also have these programs established, if you have any advice for someone who wants to bring this to their program.
I mean, I would echo.
Real quick.
The question was, what are your recommendations in initiating the discussion regarding abandoning the 6-month sobriety requirement at your center?
Yeah, I think, like I said in my presentation, everybody deserves a pathway to health, right? And that's, I think that's vitally important. And that's part of maintaining the, bioethics of it. But coming up with that conversation, the other piece of it is this is who we see now, right? The folks are showing up at our doorstep who are vitally ill, and they do not have time to get that sobriety without perishing first. And so, this is the population we see. We're treating the people where they're at, and that's why they should implement, an early liver transplant program.
Okay, I'm going to move on to the next question. Can you discuss your approach to interpreting low-level PEth 20 to 40 range, and how does this impact management of your waitlisted patients?
So PEth is highly specific. It requires ethanol in your system to form PEth. So if your PEth is above 20, that's detectable and means that you've been exposed to ethanol. In general, if they're a steady drinker, that means that they've been drinking, 2 drinks per day on average. If you have binge drinking, that can increase the levels. But certainly, unless they've received a blood transfusion or they have, auto brewery syndrome, which are other ways to get ethanol in your system without actually ingesting it, they have been drinking.
I can share as well a few thoughts about how we manage that in our program. So I agree that, if the PEth is positive, there has been alcohol consumed. I think what we're interested in is the patient being able to engage in discussion around it, to plan ahead as to how to reestablish abstinence. And also we do put them on hold on the wait list until we're able to obtain a negative PEth. And usually we have recommendations to re-engage in addiction treatment as well to better support them, because to us, we see it as a marker that they're not receiving adequate supports. When the patient denies it and is not able to engage in conversation, then that gets more complicated. And, we discuss as a team and do our best to make them as comfortable as possible to share. But unfortunately, there are people who are not able to benefit from alcohol use disorder treatment based on their inability to be forthcoming. And typically that tends to not be compatible with transplant in our program if the person continues to consume alcohol.
All right. Next question. Can you discuss your approach to assessing patients who may be intubated and cannot be safely extubated because of how sick they are, having a high MELD score, and therefore unable to participate in a psychosocial assessment? The social support may be present, but they can only provide limited background information of how they got to this point.
Yeah, for the acute alcohol-related hepatitis patients who are looking for an early pathway, that is a criteria that if they can't participate actively in their interview, then our program's not a good fit. So, namely, the thing I have to ask the patient is, do you want to transplant? Right? Is there any moral or religious objections to organ transplantation? And to gain insight. And so for our program, we stop the evaluation and move them to a center that is more forgiving in that area. And that's very tough. That's tough.
So we do transplant patients who are intubated. They have a higher bar and it's more challenging to evaluate them. So 40% of patients who were transplanted in the Accelerate Consortium either had overt encephalopathy or had mechanical ventilation. So in practice, you have to interview the surrogates. You need to really get reliable information from the surrogates. If, the surrogates don't have reliable information, then that's someone who you have to decline. Um, and you have to accept that, you're using objective data from the surrogates, but you won't be able to um, assess insight. You won't be able to assess motivation. And these patients are higher risk. So if you're going to proceed with them, they require, much more diligent and intensive post-transplant rehabilitation. You really need the resources from an addiction standpoint to manage these patients.
All right. Oh, Jose, I think you want to say
I
something.
just wanted to add, we have a similar approach in Toronto. We do transplant patients who are intubated, but it has to be a first liver decompensating event. And we have to be able to get enough collateral information from family members and others to at least identify some protective factors. And that suggests that this person will be likely to engage in the post-transplant addiction treatment and could do well.
All right. Next one, regarding the support mentioned of patients needing to have support, having others living with them who need to commit to sobriety, how does this work for patients who have AUD in their family or household or who don't have a stable living situation? It seems interesting that the roommates have a responsibility to be sober for the patient's sake.
Yeah, housing stability and support stability is a big deal. We know that's pretty well connected to success long term. And so if they have a long history of unstable housing, that ups that risk. So when it comes to social support, especially sober social support, social work works really hard to help the patient brainstorm on ways that they can garner that support and reach outside of something that might be outside of a roommate situation or outside of if the people you're living with aren't going to engage in abstinence, then really thinking outside of that box. And if that's not a problem that can be easily solved, that risk is often too high for our program to manage.
All right. If no one else has something to add to that, I think I'm going to hand it back over to our AST staff so that they can conclude the webinar.
Thank you, Dr. Lee-Riddle. Just wanted to take the time to thank our panelists and all of our attendees for today's session. Please remember to complete the evaluation survey. The recording of this session will be available soon, and thank you again.